Good evening, everyone. My name is Nim Lalvani, and I'm the director of the American Migraine Foundation. Thank you so much for joining us tonight. As you know, the mission of the American Migraine Foundation is to mobilize the community for patient support and advocacy, as well as drive and support impactful research that translates into advances for patients with migraine and other disabling diseases that cause severe head pain. If you haven't already, please be sure to visit our website to gain access to our vast library of resources and sign up for our monthly newsletter where you'll be updated with the most relevant information in the migraine and headache space. Tonight, we are broadcasting our second webinar on the topic, Potential Barriers of Access to the New CGRP Class. Our speaker tonight is none other than Dr. Amaal Starling. Dr. Starling is an assistant professor of neurology in the Mayo Clinic College of Medicine. She joined Mayo in 2012 and is currently a consultant within the Department of Neurology. Dr. Starling received her MD degree from the Drexel University College of Medicine in Philadelphia and completed her neurology residency and a headache fellowship at the Mayo Clinic College of Medicine in Scottsdale, Arizona. She is an active member of the American Headache Society and the chair of the Electronic Media Committee. Dr. Starling has been the recipient of numerous awards, including the AHS Above and Beyond Award for Service and the Manfred D. Minter Award for Excellence in Clinical Neurology. Dr. Starling's main fields of interest include migraine, concussion, post-traumatic headache, neuromodulation in headache, and medical trainee education. Before I turn this over to Dr. Starling, I want to go over a few housekeeping items. Dr. Starling will speak for about 15 minutes, after which she will field questions. If you're interested and want to ask a question, please feel free to ask them by typing them into the chat box to your right. The webinar will be available for viewing after this live broadcast as well. Dr. Starling, the floor is yours.
Excellent. Thank you so much, Nim. And I really want to thank the American Migraine Foundation for the opportunity to be able to talk a little bit about the potential barriers to access for this new class of medications, or CGRP inhibitors. So we'll go ahead and get started. And the first thing is that I wanted to review just a couple disclosures that I do have. I have worked as a consultant with Alder, Amgen, as well as Eli Lilly and Company, as well as eNeura. It's important to know because the CGRP inhibitors are produced by some of these companies, and I've also received some research funding from Mayo, as well as the Migraine Research Foundation. So over the next 15 minutes, I just want to go over a couple basics and then kind of jump into the access barriers or barriers to the CGRP class. So first, we'll talk a little bit about migraine. Seems like a simple topic, but I think it's really important to discuss as often as we can. And also, if you yourself are very well versed in knowing what migraine is, hopefully this can give you an avenue to actually discuss your chronic disease with other individuals, whether it be your friends, your family, your employers, your providers as well. Oftentimes our migraine patient advocates know more about migraine than even some healthcare providers. We'll talk a little bit about the background of what CGRP is, and then also discuss barriers. We'll talk about clinical barriers as well as talking about access barriers. And most importantly, I want this to really empower you not only with the knowledge about migraine and CGRP, but empower you with what you can do to resolve these barriers, both the clinical and the access barriers. So let's talk a little bit about migraine. Migraine is a genetic neurologic disease. Bottom line, it is not a disease that is psychiatric or psychologic. It's not because of the lifestyle you have. It's not because of the foods that you eat. It's not because of the person that you are. It is a genetic neurologic disease. In addition, it's not something that comes and goes. What I mean by that is often patients will come to me and they will say, I had a migraine yesterday, but today I don't have migraine. Or last week I had 3 migraines. I think semantics are really, really important. It's really important to recognize that you have migraine all the time. And when someone has the disease of migraine, occasionally they will have migraine attacks. I like to use the analogy of asthma because asthma seems to be something that both providers and even patients, family members, and caregivers understand. So when someone has asthma, you don't say that they have asthma today and tomorrow they don't have asthma. You say that they always have asthma. The disease is always present. It's a lung disease. And occasionally in people who have asthma, they will have asthma attacks. In addition, in asthma, there are people who may have a couple attacks a year and they just need their rescue inhaler. But unfortunately, there are some people who have more severe disease where they need something to control their disease that they take on a daily basis, and they need something for rescue for their attacks. Getting back to migraine, someone who has the genetic neurologic disease of migraine always has the disease. And on certain days, they may have a migraine attack, but the disease is always present. And of course, many of our patients, especially our patients with chronic migraine, which is defined as 15 or more headache days per month, they're fully aware of this because even if they're not having a migraine attack, they're still having symptoms consistent with migraine. So this diagram down here, if your y-axis is symptoms, there are some individuals who have chronic migraine who never get down to a 0. They always have light sensitivity, sound sensitivity, maybe a little bit of nausea all the time, motion sensitivity where you feel vertigo and dizziness. And then occasionally or more frequently for people who have more chronic migraine, you will have an attack, right? And then the attack, there may be an aura phase, there may be a pain phase, but then there's also that post-strom phase or that migraine hangover that some of my patients will call it. And then you have this period that we call interictal, or in between the two attacks. Again, for some patients, they may be lucky enough that this gets down all the way to a 0 symptoms, but unfortunately, sometimes patients will have symptoms all the time, especially our more chronic patients. So most important thing to remember is migraine is a genetic neurologic disease. I tell my patients, you are born with migraine, it's in your DNA, and you will die with migraine. What changes is throughout life, there are periods where it will go into remission, and then periods when it can be more frequent and more disabling. And then the treatment options that we use can either be preventive to manage the underlying disease process or as needed treatments to treat the actual attacks. So what are our goals to treat migraine? So number one, our goal is we want to prevent these attacks from occurring in the first place, or we're trying to prolong the time period in between attacks. The best treatment is prevention, and a lot more patients need to be on prevention than they are. What's more common is that people will be on some sort of treatment option, whether it be over-the-counter or prescription, to treat the individual attacks. Sometimes this is called acute treatment, ACUTE, or I like to just call it as-needed treatment. So when you have an attack, you would take this medication as needed. However, it's really important to prevent the attacks in addition to treating the attacks themselves. As many of you know, if you use as-needed medications too frequently, it can cause a number of problems. Not just medication overuse, which can lead to a complication of chronic migraine, which is more headaches, but also taking anti-inflammatory medications too frequently can be rough on the stomach or the kidneys. Or taking a medication like a triptan medication too frequently might not be the best thing for the rest of the body, as well as might lead to medication overuse. Again, going back to our asthma analogy, if patients are taking their as-needed rescue inhaler too frequently, it can result in more severe breathing issues or even other issues where they develop yeast infections in their mouth. So again, going back to asthma, migraine, it's a great analogy for you to think about for your own mindset as well as to share with other individuals. So the goals in migraine prevention, number one, is to reduce the frequency, the severity, and the duration of the attacks. We've also found that when individuals are on migraine prevention, it actually increases the efficacy or the effectiveness of those as-needed treatment options. In addition, it reduces overall disability and improves overall function. However, as I mentioned before, the reality is that only a minor number or small number of people who should be on prevention are actually on prevention. So about a third of people who have migraine should be on preventive treatment options. However, out of that, only 3 to 13% of those individuals are actually on preventive treatment options. So why is that? Well, it's not simply because patients don't want to use preventive treatment options. It's because we have not yet given people with migraine what they deserve. What people with migraine deserve is a preventive treatment option that works quickly, that works well, that doesn't have side effects, that is accessible and doesn't interact with other medications and doesn't worsen other medical comorbidities. And we haven't yet been able to provide patients with that. So this is something that I want you to know, that as a patient, you do deserve this. And we as a medical community need to do a better job of coming up with a treatment option that meets all of these very valid points. Now, the other thing is that we need to make sure that people have access to healthcare providers with the knowledge that prevention is needed. Now, let's talk a little bit about CGRP medications and their role in migraine. So this was initially studied from back in the 1980s, where they found that this protein CGRP, or this neuropeptide, just means protein that's found in the brain, is involved in migraine. So they would give people who have migraine, the genetic neurologic disease, an infusion or an IV treatment, or not treatment, an IV infusion of CGRP, and it would trigger a migraine attack. In addition, they found that during a migraine attack that there were elevated levels of CGRP, and when they gave those patients or those subjects a triptan medication to treat their attack, those CGRP levels went down. In addition, we found that there were elevated levels of CGRP in the blood of individuals who have chronic migraine compared to episodic migraine, as well as healthy controls. So this led to the hypothesis that if we can reduce the activity of CGRP, maybe we can treat migraine. And so what we have now available is this new class of medications. They are called CGRP inhibitors. Sometimes you hear them as anti-CGRP medications. Other times you might hear CGRP monoclonal antibodies. There are 3 that have been FDA approved, and there is another one that has not yet been FDA approved. The 3 are Arenumab, which is the generic name, and then Aimovig, Fremanezumab, and then Ajovy, and Galcanezumab, which is called Emgality. And these are all monoclonal antibodies. They're antibodies that have been genetically engineered to not have an effect on the immune system, to be highly specific for either the receptor of CGRP or the protein of CGRP. And by doing so, by attaching to the protein or the receptor, it's reducing the activity of CGRP. Now, what's important to keep in mind is that this is the only disease-specific targeted treatment option for the prevention of migraine. In fact, currently available, there is only one as-needed treatment that is designed for migraine, which are our triptan medications, and now one preventive treatment option that's designed for migraine for prevention, which are our CGRP inhibitor medications. Based on numerous studies, all phase 1, 2, 3 clinical trials where they used large numbers of patients for these studies, they were able to obtain FDA approval by demonstrating that there was efficacy with these medications in migraine. If you look at all 3 of the medications and you kind of try to come up with the overall effect of these medications in people with migraine, I usually say that 1 of 2 people, so 50% of people in these clinical trials, had at least a 50% reduction in their migraine days. So if you're an individual who has 16 migraine days per month, and if you were in these clinical trials, you would have a 1 in 2 chance of having 8 or less migraine days per month. We've now been using these medications in my practice and in our headache clinic, and we found that in clinical practice, we're seeing about the same results as they saw in the clinical trials. So it is not a panacea. It doesn't work in everybody, but in certain individuals, it can be very effective. For certain individuals, they can be super responders for whom it reduces their migraine attack frequency significantly. It works quite quickly. And there's also great tolerability with these medications. This is compared to clinical trials that were done, for example, with our other preventive oral options, such as topiramate, propranolol, or amitriptyline, where in some of these studies, in the clinical trials, there was a 20% dropout rate because of adverse events or side effects that the subjects were experiencing. That compared to the CGRP clinical trials, there was less than 2% of patients in the clinical trials that dropped out because of adverse events. So if you compare that tolerability in those clinical trials to the ones from the oral preventive treatment options, we have made a lot of progress, and that's because this is designed for migraine. Now, it is true that in the real world, we'll have to see what the medium-term and the longer-term side effects are of these medications, which is really important because that's kind of what brings us to the potential clinical barriers. So let's talk a little bit first about side effects. So as I mentioned before, CGRP is involved in migraine, but it's also involved in another body. It's involved in our endocrine system or our different types of hormones. It's involved in our stomach area, our gastrointestinal system. It's also involved in wound healing of the skin. And then also our cardiovascular system. And what it does in our cardiovascular system is it's a potent vasodilator. It dilates blood vessels or makes them bigger, specifically in situations in which there might be stress on the cardiovascular system. For example, if someone is having a heart attack or a stroke, CGRP is released to dilate blood vessels to save more heart, save more brain. And so the concern is with medium-term, long-term reduction of CGRP activity, are we potentially increasing these risks? In the short-term trials, which were 3 to 6 months, there was no evidence of having those specific serious adverse events. There has been some open label trials that have demonstrated that over the course of 1 to 4 years, we've also not seen any serious adverse events. But as I tell all my patients, this is a new class of medications, and it does a number of things throughout the body. And so right now, we don't know what the potential long-term side effects are. But of course, both providers as well as the FDA are watching the real-world results of these medications. Now, what about, is the clinical evidence applicable to you? So what do I mean by that? What I mean by that is in these clinical trials, there were specific patients that were included or excluded. So these trials included individuals that were less than the age of 65. So if I have a patient that comes in who's 70, this is not someone who would have qualified for the trial, so I'm not sure if it will be just as effective in them as it was for everyone else in the clinical trials. Now, they also excluded individuals who may have had problems with their endocrine system and their hormones, or with their cardiovascular system, a history of heart attack or stroke, or if they had significant gastrointestinal diseases or issues with wound healing. Those individuals may have been excluded because they knew that there might be this issue. And so it's important, again, when we're discussing the use of these medications in individuals who have other medical comorbidities, to determine if these were individuals who would have been potential candidates for the clinical trial, and then we can generalize these results from the clinical trials to those individuals, or if these are patients who might not have been included, and so it's hard to know if it will be effective as well as tolerated for them. Okay. Now let's talk a little bit about some access barriers as well. The first thing that I want to review, though, is just access barriers to care in migraine, and really focusing on chronic migraine because that's where the numbers are just staggering. So this single piece of data has really impacted my real advocacy career within headache medicine, that demonstrates that less than 5% of people that have chronic migraine have actually talked to a doctor about their symptoms, have been diagnosed appropriately by their healthcare providers, and have received just plain standard of care treatment. Less than 5%. It's just staggering to me that there are so many people with chronic migraine who have not even talked to a doctor about their symptoms. In fact, greater than 50% of people with chronic migraine haven't even spoken to a healthcare provider about their symptoms. So that's one of the #1 access barriers to appropriate treatment in chronic migraine, and then getting the right diagnosis and standard of care treatment. So access to healthcare is a huge issue, and talking to your provider about your headaches and migraine is super, super important, and not everyone is doing this. And maybe individuals have done it in the past, but they've given up on the medical community. Please don't give up on us. Find someone who will be able to address your issues and get to the right diagnosis. In addition, when accessing these CGRP inhibitor medications, a lot of insurance companies are requiring what we call step therapy, where you have to have tried a certain number of medication classes before you get access to the CGRP inhibitor. And the issue with that is it's time consuming. People might give up and not proceed with continuing treatment. It may lead to disease progression and a poor quality of life, as well as increasing to self-medication and medication overuse. And in fact, there's been some studies, not specifically in migraine, but in other disease processes, demonstrating that using step therapy to getting to the appropriate treatment option may actually increase costs overall in healthcare than decrease, which is what it's trying to do. And then also some insurances, and this we're trying to fight against. I know CHAMP, one of the migraine advocacy organizations, is definitely trying to fight against this. But some insurance companies are requiring that it can only be prescribed by a headache specialist. And this is crazy. This is crazy because there are over 36 million people with migraine in the US alone, 1 billion people worldwide. And here in the US alone, 36 million people with migraine, less than 500 board certified headache specialists. So making sure that headache specialists can be the only ones prescribing these medications is just unacceptable. And so we have to continue to fight the good fight on this one for sure. And then even when you get to that point, and some insurances are not covering these medications, or they'll cover it at like a really high tier, and so the copay costs are too extreme. And so these are all definitely barriers to access. So what do we do about this? We have to be advocates. There is advocacy that you have to participate in your care and kind of the logistics of your care, but then also we can take that beyond just your care to kind of address the systemic issues that occur, and even get into some policy advocacy. So what can you do? #1, talk to your healthcare provider about your symptoms. #2, get informed about migraine, the genetic neurologic disease. Use resources such as the American Migraine Foundation, the Move Against Migraine Facebook group. Use all of those resources to have tools to talk to your healthcare provider, as well as learn about migraine and other headache disorders. And then also use those to kind of bounce off of, to use for advocacy. The other thing is it's important for you to get a list of all of your preventive treatment options that you've tried. You can get this from your pharmacy, and important to have a list of those medications, the dosages that you use, and the duration of time that you used it. That will provide you the ability to present that information to insurance, and your healthcare provider the ability to incorporate that information into your clinical note so that we can get prior authorization. And then also go to the different drug company websites. I have them written here: Amgen, Teva, Eli Lilly and Company, because these are the different companies that have produced these CGRP inhibitor medications, and they have different programs that individuals can can participate in so that they can get better access. And they're doing this because they want to also get some real-world data and also be able to potentially show insurance companies that if the patient is using this medication during this promotional time period, that look, they've done well. They've not gone to the emergency room. They haven't had to get infusions. They're using less healthcare resources. And so it would be beneficial for the insurance company from a financial as well as a quality of life perspective for them to approve these medications. So if you do start these medications, we want you to keep a really good headache diary so that you can, again, have that information ready for your insurance company as well as for your healthcare provider to assist in the prior authorization process. And lastly, move that beyond just your care and participate in migraine advocacy organizations, such as the American Migraine Foundation. There's other organizations out there as well, such as CHAMP, and there's also other ones, Miles for Migraine, Running for Research. Headache on the Hill is something I'll talk about in the next slide. And all of these different migraine advocacy organizations are putting together concerted efforts to fight for what people with migraine deserve. So this is a picture of individuals that go to Headache on the Hill. It's comprised of people who are providers as well as patients. And again, every year we go to this event so that we can go to Capitol Hill and talk to our Congress people about what people with migraine deserve. Lastly, and I know I've gone a little bit over time, but lastly, I definitely want to talk about stigma, which I think is the ultimate barrier. Look at this diagram. This is showing us about NIH funding versus disease burden. And as you see, migraine is all the way down here off of this normal line. And that means that disease burden is high in migraine. And we should be getting funded around $200 to $250 million per year from the NIH, but we're not. We get funded about $20 million per year. And why is that? It's because of stigma. People with migraine have received so much external stigma that they internalize it and feel like they don't even deserve what they truly do. People who take care of people with migraine don't realize how important taking care of people with migraine is. I remember as a resident when I was considering doing a migraine fellowship or headache fellowship, a lot of other neurologists said to me, well, why are you wasting your career in migraine? And I started wondering, am I doing the right thing? I know now that I am, but that's that stigma about migraine. It is a true genetic neurologic disease. It is one where the physiology is very important for us to figure out so that we can treat the disease better. So you deserve more. People with migraine deserve more. You deserve more access, more care, more treatment options. I want you to demand more. I want you to be as relentless as migraine because you are a migraine warrior. And I want you to know that you can correct this situation as much as possible by participating in advocacy. Make advocacy a part of your treatment plan that will empower you. It will bring that locus of control that migraine is taken away from you and taken away from you so that it's controlling your life. You need to regain that locus of control and be a migraine advocate and a migraine warrior. So I will stop, and I hope that we have some time to take a couple questions. I'm sorry that I ran a little bit late, but if you have questions, please post them in the chat section, and I will be happy to answer them. I don't see the questions, but oops. Oh, here we go. So I see the questions under questions, but not under the chat. If you guys can let me know if I should be going to the questions section or if I should be going to the chat section. Oh, perfect. There is one question here. And let me get to this screen. All right, and so one of the questions from viewers that was there. Are the new CGRP inhibitor medications advisable to be used by older individuals? So that's a great question. And so as I was mentioning before, individuals older than the age of 65 were not included in the clinical trial. And so it's hard to know if the data, so both the efficacy as well as the safety and tolerability, is generalizable to individuals who are above the age of 65. However, we don't have any pathophysiologic reason or biologic reason why it should be less effective in people who are greater than the age of 65. And as long as an individual does not have significant medical comorbidities, specifically heart disease and history of stroke or heart attack, these are things that will likely be effective and well tolerated by them. So in my own practice, I do have many patients that are greater than the age of 65, and as long as they don't have other significant medical comorbidities, it is a treatment option that I have considered for them. And I have a lot of patients who are older than the age of 65 who had benefit as well as good no side effects or limited side effects from these medications. So hopefully that answers your question. All right. I have another question. When an individual begins to take one of the new CGRP treatments, do they wean off of their other preventive treatment options or triptans? That is a great question. So currently, number one, remember your triptan medications are your as-needed treatment options. And you always need an as-needed treatment option, and you may need a preventive treatment option as well. So to answer the first question is, should they stop their triptan medications? The answer to that is no, because even if you're on a CGRP inhibitor medication, the likelihood that you will have 0 migraine attacks ever again is very, very unlikely. You may still have migraine attacks. The hope is you have at least 50% less of those migraine attacks. But when you have your migraine attack, you need to be able to use your as-needed treatment option, which for most patients are a triptan medication. Now let's talk about the second part of that. The second part of that question was, what about the other preventives? So for the most part, if someone is on oral preventive treatment options, or if they're on onabotulinum toxin injections or nerve blocks for prevention, for the most part, we're using the CGRP inhibitor on top of what their current preventive treatment options are, unless maybe they're having side effects from their treatment options, and then we'll wean them off of those treatment options. I will say that unfortunately, some of the insurance companies have been forcing patients and providers to choose between a CGRP inhibitor medication and onabotulinum toxin injections. There's not a medical we have for that. It's simply because they're both expensive treatment options, and so the insurance companies are asking for us to choose one or the other. But in general, from a medical perspective, is I add on the CGRP inhibitor treatment on top of what they're already using for prevention. And then if they have a great response to the CGRP inhibitor, we're able to slowly wean and discontinue the other treatments and oral medications. All right. Here's another one. And maybe I can take one more question after that. But I know it's pretty late for all of you on the East Coast, and so I don't want to keep you up too long. So here's another question. Why would Aimovig work for 2 months and then stop working? Should I try another CGRP now? So first of all, I'm happy to give you information during this webinar, but of course I can't give specific individual medical advice. But in general, I think it's important to talk about why medications work or don't work, or why something may work for a couple months and then seem like it's not working for another month. So first of all, sometimes patients of mine will ask me, why can't you guys figure out a treatment option that works for everybody with migraine? It's important to consider that, remember I said that migraine is a genetic neurologic disease? But what that means is there are a number of genes that can contribute to the migraine disease. In fact, in the most recent review article about genetics and migraine, there were over 44 different genes that were associated with migraine. So as you can imagine, different people with migraine will have a different combination of these variety of mutations. And so we don't have, and I doubt that we'll ever have, one specific treatment option that will work for everybody with migraine. But what I hope that we have, and I feel like we're moving towards that relatively quickly right now, is that we have a variety of treatment options for different people who have different types of migraine. And hopefully in the near future, we will have individualized treatment where I can take a patient's blood and I can say, based on your blood test, you have this type of migraine, and based on that, this specific medication will work for you. But for another patient, it might be a different genetic biomarker or blood biomarker, and for them, a different treatment option will be effective. We're not there yet, but that's what I hope that we will get towards. So it is true that the CGRP inhibitors won't work for everybody, but there may be certain individuals that have a lot of CGRP activity in their migraine, and for them, this may be helpful. The other thing to keep in mind is that migraine has a very up and down course. And so unfortunately, there are sometimes patients will have a really good month and then we'll have a really bad month. So I always encourage not only myself, but also my patients to be patient, not only with the medication, but also their disease process, that there are minor fluctuations that can occur, which may not actually be related to the medication, but actually be related to the underlying migraine disease process. Plus, any preventive treatment option, it doesn't just take away the disease, it just increases the threshold for a migraine. In the usual state, my threshold for migraine may be down here, but if there is a bad weather front coming in, then my threshold is a little bit lower. Or if I've had a bad night of sleep, it might be even a little bit lower. Or if I've had a lot of processed foods, it might be even lower and that much easier to cause a migraine attack. So what do all preventive treatment options do? They increase your threshold for having a migraine attack. But still, if there's a lot of stress, or if there's a lot of weather changes, or if there's different allergens in the air, it may be enough to overcome that threshold and still cause an attack. So it's not just about the preventive treatment option, but it's still about all the other potential triggers that can have an effect. All right, so I will actually, let me just take one look at the section with questions and see if there's one last question that I can answer. And actually, it's quite a long question, so perhaps I can answer that one later. And then let me just check the chat section again, if there's any quicker questions. All right, well, what I will do now is I will sign off, but before I do so, I want you to know, again, that you deserve more. Don't forget that. Demand more. Be your own advocate. Be a migraine advocate, because you are a migraine warrior. We need you to change the stigma of migraine. We need you to be the one who changes the access for treatment of migraine. If you think about it in all other disease processes, it is finally the patients who are able to make that change. Think about breast cancer, autism, HIV and AIDS. The patients and the caregivers are the ones that destroyed the stigma, the ones that were able to advance the research and the funding. So we need you to be your own advocate and be advocates for all people with migraine. So thank you, and I'll turn it over to Nim.
Thank you, Dr. Starling, for that informative presentation and dedicating your time to continue to educate and advocate for our community of patients living with migraine. The American Migraine Foundation would like to thank our community of patients, families, and friends for their generous support, and to our corporate and industry sponsors for making opportunities like this possible. Again, please visit our website at AmericanMigraineFoundation.org to gain access to our expertly curated resources and join our Move Against Migraine community on Facebook. Thank you, everybody, and good night.